King, and I head up the Transformational Change Mental Health Unit at Healthcare Improvement Scotland. It's delightful to know that we're already 336 of us in this virtual room. What I will say is that because we are so large in number, it means that you won't be able to put your cameras on at the moment unless you're a speaker, and you won't be able to unmute yourselves yet, although there are points in the webinar later when you will be able to do that. But in the meantime, while we're just waiting for a few more people to arrive, if you would like to introduce yourselves in the chat to say hello, thank you to those of you that are already doing that. That would be great. You could also add which part of the country you are currently in. And if you want, you could mention why you were interested in attending this webinar. And also, if there's more than one of you sharing a screen, do feel free to introduce all of you that are around. Okay, so we're already getting a question that is technical, and I would like to just highlight that to Nicola and Becca, who are our technical high wizardesses. So Nicola Graham and Rebecca Morrison, could you possibly put your details in the chat so people know how to get in touch with you should they be having any technical issues? I can hear a lot of people now managing to introduce themselves, which is great. Good morning, good morning. We've got people from all over the place. Thank you. We've got Tim with his hand up. Tim, will probably, could you put your message in the chat, please? That would be great. And while people are just mentioning themselves in the chat, thank you, everybody. We will just make a start, I think. So, good morning, everybody. It's lovely to see so many people here with us this morning. And thank you to everybody who is managing to introduce themselves in the chat. It's great to be here. As I said earlier, my name is Rachel King and I'm from Healthcare Improvement Scotland. I head up the mental health transformational change work there. And I'm just going to be chairing and introducing for this morning's webinar. So the first thing that we're going to do is just check in about a little bit of the agenda and the housekeeping. If we could move on to the next slide, please, that would be great. So the agenda for today is the welcome initially from me, but I doubt that any of you are here today in order to hear me speak. So I will then be introducing our two keynote speakers, Dan Warrender and Andy Williams, and you'll see the things that they are going to speak about, their ethical approaches to risk for people diagnosed with a personality disorder and clinical application of the action and consequences model across clinical pathways. We would then like to hear from yourselves about how you found those presentations and what that means to you for your own practice. We are aware that this is a large group of people. We're nearly hitting 500 in number already, and we will do our best to make it as interactive as possible. We want for you to be able to take away from today something that you can apply in your own work and in your own locality. We're then going to be joined by Dr. Jane Cheeseman, who will be taking the Q&A session. So do, as we're going through both presentations and the rest of the morning, do please pop your questions in the chat. We would be delighted to pick up on everything that we have time for, and we'll be looking and monitoring the chat throughout. So if you have anything that you wish to mention, please do put it in the chat. So Hopefully Nicola and Rebecca have introduced themselves in the chat. If you've got any issues at all, please do get in touch with them. This webinar will be recorded and there will be a link shared around that, so you don't need to record it. It will all be there for you, and for colleagues and for others who will benefit from it. Okay, I think next slide, please. This is just about Teams. Hopefully you're very familiar with it. So do put your questions in the chat. That's at number 1. If you have accessibility that you would like to access, look under number 2, under more, and you'll find language and speech, live captions, live transcript of the meeting. Your camera's going to be off, as I said, your mic will be off. And then at the end, at midday, we will all leave the meeting. If you do have any problems, please get in touch with Nicola and Rebecca. Thank you. Next slide, please. So the only other thing that I wanted to mention before I hand over, well, there's actually 2 things I wanted to mention, but one of them was this. So this webinar is a mental health reform webinar, and we've been delivering the reform programme in mental health at Healthcare Improvement Scotland for nearly a year now. It ties in with the NHS reform agenda from Scottish Government, and it is about how do we do better to think about not just our needs now to support people, but also to look at what are our needs in the future, and how do we design and develop and deliver services and supports for people right across Scotland that make sense, that are evidence-based, that are high in quality, and that deliver the support that people require. Within Reform, we have these 4 programmes that really join together to look at, these are some of the really tangible issues that people face day to day, both seeking support and delivering support in mental health. So I won't dwell on these this morning, but I think you can see that the personality disorder improvement, which is the second block there, really is looking at areas of good practice, which is what we're doing here today, looking at gaps in quality of data collection, looking at how many people are seeking support, in what ways is that being delivered, what would be better in terms of our understanding of what people are needing and where is good practice happening, and thirdly looking at clinical training and support. So hopefully by the end of today you come away with some of those aspects of this work. In addition to that, we've been looking at early intervention in psychosis. We have supported the setup of 2 new services, one in Dundee and one in Dumfries and Galloway. We're now working with another 2 places to look at how do we take that new service model further, looking at, we know there's a really good evidence base around how to support people with first episode psychosis, and we also know that there's a lot of constraints on the mental health system as it is. So how do we take that evidence-based model and the constraints that we know are there and create something that works to support people and delivers good outcomes? And that is what we've managed to do alongside our colleagues in those local areas. So if you are interested in hearing more either about our wider personality disorder work or about our work in psychosis, please do pop your details in the chat and we can get in touch with you around that. In addition to that, we have 2 other programmes. One is called Coming Home, which is about the coming home agenda from Scottish Government around how do we manage to support people with really complex support needs, often with learning disabilities, sometimes with mental health support needs as well, often with physical health support needs too, often for long periods of time or a lifetime, closer to home. So how do those people get the care that they need closer to home? So we've established a peer network of professionals. If you're interested in joining that, please do put your details in the chat. Our aim is to identify good practice and support the planning for complex needs. And joined to that piece is therefore our work around delayed discharges in mental health and learning disabilities. We're working at pace with 2 areas in Scotland to look at what tests of change can we put in to enable change to happen around the delays in discharge that we find either in acute settings or in particular in learning disabilities settings as well. So within that piece of work, we're joined to both the coming home work, but also to things like the psychosis work and personality disorder, where people enter into acute settings and there isn't necessarily the care package for them to come back out. We are looking at the moment at what we will be taking forward for the next financial year. We're in the planning stages, and we are taking this work alongside some other pieces forward over the next year. We would be delighted if you wanted to get in touch or stay in touch about any of that. So please do put any of your details in the chat. The only other thing that I wanted to say before I introduce today's speakers is to say thank you at the beginning for to the team for creating and organising this event. You can see that we are now sitting at 520 people attending this webinar. We had over 1,000 people ask to attend. We are delighted that there's so much interest in this area, and that the work and the speakers and things that are available through this webinar series are really meeting and joining with the priorities that you see yourselves in local systems. So I just wanted to call out at the beginning of this webinar my thanks to Ashley Hose and Nicola Graham and Rebecca Morrison and Deb Creedy for putting together this webinar, for bringing all the tech and all the support and all the thoughtfulness and the speakers into today's webinar. And I also wanted to extend my thanks to Jane Cheeseman for being available and happy to take the Q&A as part of the programme today. So I'm going to introduce our first speaker now, Dr. Dan Warrender, and Dan has been is a registered mental health nurse and is a lecturer in mental health nursing at Abertay University. Dan has worked for over 10 years in mental health nursing education and is particularly interested in personality disorder, looking at experiences of working in acute mental health and psychotherapy into writing and his research. And Dan started the campaign group Mental Health Deserves Better, which actively looks at not only having generic nursing education, but argues for mental health nursing education and mental health nursing role to be recognised specifically. Dan will be talking to us today about the Action and Consequences Model Revisited, thinking about ethical approaches to risk for people diagnosed with a personality disorder. And Dan, I would like to introduce you now. Thank you so much for being here with us this morning, and it's over to you. Thank you.
Thanks very much, Rachel. Hopefully everyone can hear me, and people will very quickly let me know if they can't. Good morning. It's really odd saying good morning and hello to over sort of 500 people that you can't see. There's something really disconcerting about that. But hello, it's nice to not see you, but it's nice that you've attended, you're interested in this, and I hope I can make myself useful over the next hour. So here's my title, the Action Consequences Model Revisited. So a model that I developed kind of a few years ago and kind of looking at it again based on some new data. Ethical approaches to risk for people diagnosed with personality disorder. And that's a jelly there with risk on it that will be explained as we move on. Next slide, please. So what I'm going to try and do is contextualize ethics and risk in the care of people diagnosed with personality disorder. I will introduce the model as a tool to aid critical thinking, and we'll kind of try and bring that model to life by using some theory and qualitative data around crisis care that I'm going to pull from my PhD. Next slide, please. So the first thing to say is, I guess, just to mention the controversy around the label. You know, I mean, I think that it's not something we're going to focus on here, but I think it is important that we do kind of acknowledge it. So I've used inverted commas around personality disorder for probably kind of maybe not quite 10 years, but getting towards that, really just to sort of highlight that there is so much debate and disagreement around the use of this label. I think it might be the most controversial label in all of kind of mental health care. Some people find it associated with a lot of kind of stigma. There's a ton of comorbidities. So a person that might be diagnosed with personality disorder is also likely to be diagnosed with other conditions as well, which sort of complicates that sense of like, what is it that we're dealing with here? What are we treating? There's a lot of debate around, are difficulties better explained as trauma responses, such as the kind of conflict between, should we just use complex post-traumatic stress disorder, or should we use personality disorder? And now lots of debate around neurodiversity, I think particularly with women, is it undiagnosed ADHD or undiagnosed autism? Lots of debate around that. So there's lots of scientific, sociological, philosophical, and pragmatic debates that are raging on around the concept of personality disorder. But I'm wanting to focus on what we maybe do agree on today. And what we probably do agree on is that we do see a group of people that might be emotionally overwhelmed, find interpersonal relationships quite difficult, might be impulsive, and might recurrently harm themselves and attempt suicide. And I think that's what we're kind of really sort of thinking about here. So despite what we might call it or the ways that we understand it, this is what this sort of model might be useful for thinking about. So it's a really important discussion, but we don't have sort of time to dive into this and do this justice here. Next slide, please. So just a bit of context around ethics. Hopefully everyone is sort of a little bit familiar with these kind of ethical principles that I'll quickly run through because it gives an important context for what we'll talk about later. So beneficence, essentially the idea that we do good. That's what we want to do in healthcare. We want to be helpful, be useful, and want to help people. Non-maleficence is the idea of doing no harm. And I think we do work in a grey area in mental health. And the idea is, if there is harm, the harm has to outweigh the good. It has to be justifiable in the sort of in the pursuit of kind of maybe improved long-term goals. So we're doing this thing, might be harmful, but the benefits are better on the other side of that. Autonomy. Obviously something that we want to respect, and you can quickly see how this gets complicated in the context of suicidality. If we are to respect a person's autonomy, what happens when they are freely choosing to hurt themselves? What do we do in that kind of circumstance? And then you quickly get into that sort of grey area. And justice is important to consider here, I guess, particularly around the stigma that goes along with the personality disorder label. So justice is about fair, equitable, appropriate treatment of people and our healthcare resources distributed fairly. And we know that sometimes people with this diagnosis maybe aren't treated as well as they should be as a result of that diagnosis. So that's something to kind of keep in mind as we're going through this as well. Next slide, please. A bit of ethical philosophy in the morning. That's what everyone wants with a cup of coffee. So there's three kind of main schools of kind of philosophical thought around ethics that I think are quite important to keep in mind. So deontology is basically the idea that what's right and wrong is it's rule driven. There's clear rules. This is right and this is wrong, and this is what kind of needs to happen. I think we can quickly see that it doesn't really fit with mental health care, particularly when we're talking about the non-maleficence. And if there is bad that is going to happen to someone, then the good has to outweigh it. So that sense of there's just clearly a right answer, clearly a wrong answer ethically, I don't think that really fits the reality or the complexity of mental health care. Virtue ethics is about the intentions of people. So it doesn't matter the outcomes of what I do. It's about my intentions and my kind of, I guess, my noble heart or characteristics, or the kind of person that I'm trying to be. Which again, I don't think really cuts it, because consequentialism sort of jumps off the page for me in terms of being probably the most appropriate ethical philosophy for thinking about mental health care. And that's about so what's it say here? Choices, acts, or intentions are morally assessed on the states of affairs that they bring about, and the moral worth of an action lays in its consequences. The complexity is that we sometimes don't know what the consequences are going to be when we perform an action. And I think mental health care needs to look here because it's too complex for this sort of clear rules. So we need to think about what is being done and what are the consequences of that for the person. I hope this is making sense, a little bit of sort of crash course in ethics and philosophy, and I can't see confused faces in the same way that I normally do when I'm teaching a class, but hopefully it's sinking in. Next slide, please. So we've got trying to be ethical in the context of risk, which is really, really complicated. So risk in mental health care, I think it's often considered quite narrowly. You know, I mean, the things that jump off the page at us are violence, self-harm and suicide. I think those are the things that kind of people immediately think of when they think about risk. But I think it's useful to consider risk much more broadly and consider not just risk that might exist within service users, but risk that comes from services as well. I think we really need to start to think about that. So risks, a chance of losing something of value, and people might value different things. Now, also, of course, we value life. Yeah, I mean, so risk to life, a risk is losing something of value. That's something we really need to think about. But what about a risk of a person losing their autonomy, losing their independence, losing their social skills? Yeah, I mean, losing their psychological sense of safety. We can think about it quite broadly. So risk can appear in many forms, might involve one event or repeated events, can be imposed on a person or arise from their own actions. I guess that goes back to that bit of what's happening within the person and what's happening from services as well. Can have immediate or delayed effects, impact a person directly or indirectly. Impacts can be material or psychological, incredibly important. And, you know, I mean, you would think that in the mental health business, we would sort of be focused on the psychological, but I think sometimes we are maybe focused too much on the material. We're focused on that bit that we can see, and we maybe lose that sense of what's going on for all the individuals involved. And outcomes may be certain or uncertain, and that's why we need to think about not just what we do, but what are the consequences of what we do as well. Next slide, please. So I think it's about that quest to get this just right, which I think was probably much easier for Goldilocks. You know, I mean, just looking at that kind of what's too hot, what's too cold, and what's in the middle. There's much more nuance and interpersonal mess to work in this way. Now, like, approaches to people in crisis have been known to range between two extremes, and I've sort of called these the too cold and too hot. So too cold, an exclusion from services, we don't admit them, it's their responsibility, versus too hot, risk aversion, it's our responsibility, you can't keep yourself safe, defensive psychiatry. And I think the reality is we've got to try and make peace with floating in the nuance of this. I do wonder if the sort of sense of these being binary decisions maybe comes from, I guess, a bit of anxiety around that nuance. The nuance is so complicated. It's so rooted in the mess of interpersonal relationships and people's previous histories that it's really difficult to find the answer. It requires a lot of kind of creativity. And I do wonder if that maybe pushes us towards these binary decisions of kind of just being very rule or policy driven, you know what I mean, that we just don't admit people, or we do admit people and actually there's a risk, so we don't let people go. And I think that's where a lot of this model came from, was my experience of talking to people that felt really excluded from mental health care, felt that they weren't getting access to crisis care or longer term therapy. But then on the other hand, seeing people that had maybe been detained in hospital for years and years and years, and you think there's something wrong here, because some people are feeling excluded and some people are feeling essentially, you know, I mean, detained almost indefinitely. So to be person-centered and to get this just right, this requires careful thought. And I think that maybe what the model that I will introduce does is sort of help with a bit of that nuance. Next slide, please. Okay, so the action consequences model, so some references there, and I'll give you links to all that stuff at the end. So it's a model to aid critical thinking and decision making where risk is a concern. It's used by some clinical teams in the UK to kind of aid their case discussions, and then quality improvement projects. I think the good thing for me, which is, I guess, quite flattering, or it's nice to feel that you've been useful in the world, is that people have kind of picked this up and sort of used it independently of me. I mean, I wrote this stuff and I put this stuff out there, but people have found it useful and they've kind of independently sort of chose to use it and start kind of bringing it into their work. And I think that's validating and hopefully encouraging for other people that might find it useful as well. Is that, I mean, people can take it and find that they can sort of fit it around their ways of working, and it maybe enhances their kind of thinking processes. Now, the model's yet to be evidence-based. Now, I'm not going to sit here and be a kind of used car salesman and tell you this is amazing, this is going to change everything about your work and satisfaction guaranteed, what I mean, this is going to improve outcomes. And you sometimes wonder in outcomes, what are we even counting actually with outcomes? What is a measure of success? I don't think we even always know that. So I'm not going to say this is evidence-based and this is going to guarantee any particular outcome, but the model is based in evidence in terms of the things that I will talk about across the model. These things do happen. They do occur. So it's about asking questions, provoking thought based on the consequentialist ethics and whether there is help or harm. And I guess some kind of prompts for people, if you were to use the model, is asking what has happened to a person as they've been through mental health care, what is happening and what might happen, what's going on here, are we helping or is this being unhelpful and actually harmful, and what might we consider doing differently. So just some really kind of open prompts that you could use based on this model. Next slide, please. So I want to be really honest about the limitations of this. I love these two quotes here. So all models are wrong, but some of them are useful. And a map is not the territory. And I think that's useful. I mean, I don't want to kind of sit here as an armchair academic and kind of come across as like having sort of all the answers, because you know what? It's pretty easy from sitting at my computer to kind of tell you that, yeah, I think this is what you need to do. But the reality is when you are in the midst of dealing with decisions around risk and everyone's anxieties are up and everyone's full of adrenaline, it's not easy at all. It's absolutely the opposite. So this is not a how-to. Humans are too complicated and there are too many variables, and I wouldn't patronize anyone by telling you this is exactly what you do, because it's complicated. It's a guided discussion or reflection tool for the entire multidisciplinary team. I think I would emphasize that actually everyone kind of has to be on board with what you're doing here. But it's a useful tool that can maybe help you argue your case. If you feel something is going in a harmful direction rather than helpful, maybe this is the model that might be helpful in terms of kind of framing your discussion. This is some of the things that I think are happening. What do you think? And again, we just talk about it and try and think about it and try and provide the best care we can for people. And there will always be dynamics not accounted for by the model, because working with risk happens in the context of human relationships, and there's just no roadmap for human relationships. If you go back to that quote, the map is not the territory. I guess it's like a roadmap, but it doesn't tell you where all the potholes are. And there's a bloody lot of them now, isn't there? There's loads of them everywhere and keep wrecking the tires of my car. And I think in this kind of work, there's a massive amount of relational potholes. The kind of the massive amount of sort of unpredictability that goes on when human beings are talking and communicating with one another. So, and then the picture there, it's not a magic wand. So hopefully I've kind of made myself suitably humble and lowered your expectations so I can kind of talk about the model. Next slide, please. Okay, so this is the model. It's not very eye-catching or exciting to look at. And what I'll do over the next few slides is sort of try and talk about key aspects of this. So I'll kind of try and take you on a bit of a kind of guided tour. You'll see the actions down the left-hand side of essentially containing risk or tolerating risk. I'll explain them in a second. And the potential consequences, again, because we don't know what consequences are going to happen along the top. And we've got benefits, dangers, thinking about short-term and long-term, and thinking about the interpretation of motive and that kind of bit of communication that really sort of ties all this stuff together. Now, the model really lives, and I guess it comes alive when you're thinking about inpatient settings. And I think that's where the model kind of really started for me in my head, in my thinking. But I do think there's principles that are useful in kind of thinking about risk in any kind of context as well. And I think I'd sort of be very encouraging of people to sort of adapt this to meet their needs. And that's what the teams that are using it have done. They're not asking for my permission or approval, and I wouldn't want that, you know what I mean? Because I don't know the context that you guys are all working in. Next slide, please. So, containing risk or tolerating risk. Now, these are both actions you'll notice down the side of the model, because I think it's important to think about these things as both active stances. It's not just that the containing risk is doing something and the tolerating risk is doing nothing. I think it's an active thing if it's thought about and if it's well communicated as well. And I think you should think about containing risk and tolerating risk as essentially a spectrum between two extremes that I will kind of outline. So containment, it might include the use of kind of chemical restraint. You know, I mean, it could be the use of sort of psychotropic medication, legislation, including the Mental Health Act, might include observations or continuous interventions, as they should now be known, could include physical restraint, seclusion. So at its extreme, containing risk in mental health care would be a person detained under the Mental Health Act, hospitalised on continuous intervention, observation, medicated and restrained. Now, we want to avoid that if possible, but that is the extreme of containing risk. We can get right up close to a person, literally pinning them down to the ground, which is horrible. And we need to kind of really think carefully about the ethics of that. Now, also importantly, just a little bit of a teaser for sort of later on, and actually the thing that brings this all together. Importantly, containment can happen through relationships. So this containment stuff, sometimes it needs to be some of those more physical or legislative things, but it can happen within relationships as well. So keep that in mind as we're moving forward. Now, the other end is tolerating risk. So I think tolerating risk involves accepting that some risk is inevitable, and risk can never be fully eliminated. I mean, I think human beings are unpredictable, and I think there's a risk of anything everywhere, all the time. Obviously, we have to be sort of sensible about it, and there's times where we have to think about it much more than others. But it's a myth that we could completely eliminate risk. So it's an active stance considering the benefit of tolerating risk, which might benefit the person. And at its extreme, tolerating risk would be a person having full autonomy with no input from services. So two ends of the extreme, like mental health services having essentially complete control over a human being, or having absolutely no control and no input. But that being sort of probably felt as a kind of a beneficial thing for the person as well. Next slide, please. So hopefully that makes sense. This kind of somebody that I interviewed that kind of popped out at me as kind of a little bit of a, you know, I mean, where people can really feel this. So the crux of the issue might be, are we sometimes tolerating too much, or are we sometimes containing too much? And a person said that time last year was the first time in years I'd been like, take me into hospital. I was begging them to keep me and they wouldn't keep me. A person feeling really at risk to themselves, feeling that without intervention, they were at risk of dying. And then they're saying, whereas other times they take you in and you think, that's not what I need. And I think it's about that bit, and that's the complicated bit, is thinking about what does a person need and how do we how do we best get there. Next slide, please. So the benefits of containing risk or tolerating risk, important to recognise that each approach can be justified as ethical. And this is where that deontology, that clear right and wrong, it just doesn't fit what we do in mental health care. Now, the containing risk, the benefits are that if you don't contain risk, it might include significant and lasting harm for a person. And actually, a person's physical safety might depend on a containing intervention. So actually, without that, you might sort of, you know what I mean, probably be in a position where it's unethical due to an omission, you know what I mean, due to not doing something, due to not intervening when we probably should have. The benefit of tolerating risk is obviously that it promotes human rights and the ethical principle of autonomy, and it's least restrictive. You know what I mean? One of the key principles of the Mental Health Act, and ultimately, I think it's what we want for all human beings. Is, you know what I mean? Is want us to have as much control and influence and freedom in our own lives as humanly possible. So there are benefits to both of these approaches, and I think it's important to keep that in mind. Next slide, please. Now, the dangers of containing risk, and this is where I'm sort of bringing in a little bit more of the quotes from people that I spoke to. The dangers of containing risk is that the way that we contain risk might be re-traumatizing for a person, or I mean, you could argue it could be traumatizing for the first time sometimes, if people are kind of restrained, etc. And I'll read out some quotes here. And I think we have to ask, does safety feel safe to the person? Because we can say that we do things in the name of safety, but do people feel safe as these things are occurring? And this is thinking about the consequences of the thing that might be justified in terms of having good intentions, etc. But again, some of the consequences are much more complicated. I'd be like grabbed and manhandled by multiple people. Being restrained and bound is traumatizing. People pinning you down. Someone else saying it was definitely going too far. It seems very extreme. I think has caused more trauma than was helpful at the time. So again, that's kind of breaching that non-maleficence, isn't it? It's kind of that this was harmful and actually it was more harmful than it was helpful. So if you can try and get that balance right of kind of this wasn't a good thing to do, but it was good in the context of kind of longer term consequences. It had to happen for this kind of good outcome, but sometimes people are feeling that actually, no, it's just harmful and it's not helpful on the other end. And somebody saying it took me quite some time to get over what I'd been through in there, talking about being in hospital, let alone getting over why you were in there. It was sort of two recoveries at once. And the idea that actually a person needs to recover from their initial crisis or what has sort of brought them into contact with mental health services, but then also recovering from the input of mental health services. And again, we're really starting to see that kind of principle of non-maleficence being violated and the consequences not being good for a person. Disempowerment as well is a kind of complicated one. I'll read these quotes out and then I'll sort of think about them. So there's something about it just being in hospital and being cut off from your usual coping mechanisms and things, in the sense that if someone's locked the door and said, I'm not allowed out, then I can't go for a walk. And actually going for a walk's really good for me to regulate my mood and stuff. So that containing measure or intervention gets in the way of a person's usual coping mechanisms. So you prevent a person from coping in the way that they normally would. And actually what then happens is that this can kind of lead to a deterioration in a person's mental state. You know what I mean? They've been cut off from that thing that they usually do. And it gets much more complicated with this next quote. But also in more negative coping strategies in terms of self-harming things, it's very much come into hospital and you're not allowed to hurt yourself anymore. But we didn't actually mind if you were hurting yourself at home, like that was fine. Now, this could kind of go down the rabbit hole, isn't it? You know what I mean? We could talk about this for a long time, the ethics around that. I guess what I will say is, and I guess without sort of diving into that kind of ethical minefield, is talking about if we are going to remove a person's coping mechanisms for whatever reason, this is going to be problematic unless it's kind of replaced with something of equal value for that person. So however a person copes, if we stop them from using that, then perhaps they're going to try and cope in different ways. And some of these different ways actually can become more risky and more violent and more dangerous. So again, I think going back to my humility, I'm not going to tell you exactly what to do here. I'm just telling you these are incredibly important things for us to sort of think about. And thinking about the re-traumatization again, you know, I mean, is actually people with these sort of diagnoses have sometimes experienced kind of incredible, horrific things in their life, you know what I mean, incredibly invalidating and traumatizing experiences. And this experience of powerlessness can kind of replicate that. Next slide, please. We could talk about any one of these slides for like hours and hours and hours, but hopefully folk are getting a bit of a flavour. Now, the dangers of tolerating risk, you know, I mean, to show you on the other side, I mean, these things can be ethical, they can be unethical as well. So re-traumatization and invalidation. And again, I'll sort of go through these quotes here and then think about them. So a person saying, I was begging them to keep me and they wouldn't keep me. And a community mental health nurse talking about a person that they worked with said their mental health care would have helped had the response been healing, had it been the opposite of our childhood. But unfortunately, it was the same. It was still a little girl crying in a room and banging her head and it just being annoying. So describing that experience of people feeling like they were kind of essentially not emotionally seen or not kind of validated by mental health services. And it's just that repeatedly in life. And then when you get poor care, you think, am I wrong? Is it me? There was people talking about sort of experiences of kind of childhood neglect and then feeling sort of, I guess, having that neglect revisited when they were in kind of mental health services, feeling neglected by people that were sort of actually employed to care. And I think that adds a real complexity to people's sort of sense of self and self-worth and self-esteem when that occurs. And obviously, probably the most startling and worrying danger of tolerating risk is that people can die. So is there a danger that actually sometimes if we are tolerating risk that we can be complacent and significant and lasting harm can occur as a result of that? And I think this quote's important here from a person. So the only thing that I can control is self-harm and attempting suicide, but sometimes it can also be out of control as well, which is the scary part. So it's not like a predictable and controllable thing, even for the person. And I think sometimes we might kind of get complacent and think that if a person has attempted suicide or hurt themselves lots of times, but actually they've been alive on the other side, that this is always going to be the case. But I think it's the fallacy of induction, you know. So the induction is a scientific kind of philosophy or way of gaining information. And I guess it's the idea of kind of you look for patterns. You know, I mean, like the sun has risen for every day before now, so the sun's going to rise forever. But I remember one of my philosophy teachers talking about the chicken. You know what I mean? So the chicken wakes up in the morning, goes out, and then it kind of farmer throws seeds on the ground, and it pecks and it eats seeds, and this is life. So it just assumes, right, this is happening every day, and then what happens one day is chicken stew or chicken pie. You know what I mean? There's an end to this that was maybe kind of unpredictable and unforeseen. And I think that can happen with people as well. And there's a lot of public reports and inquests of people dying with missed opportunities to help them. And I pulled some of these, I guess, reports into my PhD. And the one that sort of stands out for me was a report in the UK of a person that died after staff believed that they were pretending to be unconscious, and CPR was delayed for 10 minutes as a result. So I think it's important to emphasize that can happen. And this is where it gets really difficult, isn't it? Because containing risk too much is not good, but tolerating risk can have dire consequences as well. And again, I didn't say it was going to be easy. I just said these are things that we need to think about. Next slide, please. So short term, which is distinguished from long term in the model. And I think this is where, like mental health services, if we're doing it well, we're really earning our money in terms of trying to think about when short-term risk and that acute risk might be distinguished from, I guess, a more chronic or baseline risk. And I think that's a really, really difficult thing to do. But I think that's what we really need to kind of try and think about and focus on. So some people distinguish, so Bateman and Krawitz, it's a kind of good book. Episodic acute suicidality is distinguished from baseline suicidality. I mean, some of this kind of suicidal thoughts and suicidal feelings might have a kind of chronic element to it in terms of it's sort of a person's normal, for want of a better word. You know what I mean? This is kind of a sort of day-to-day occurrence for them. And actually, sometimes that risk might spike really, really quite rapidly. And I think that's a difficult thing to do, particularly in the context where, you know what I mean, now, I guess, sort of there's more and more evidence coming out about the sort of the very limited value of risk assessment tools. So actually, the risk assessment tool, I think the best one is a relationship between you and the person, and actually kind of building up trust and understanding and being able to communicate effectively. That's the best way of trying to assess risk. And NICE guidelines as well. Acute risk is distinguished from this long-term risk. And I think this is a really, really complicated place to be. But I think if we focus on relationships, that's maybe a way of trying to get there. And I guess it's maybe about sort of thinking about that real spike of risk versus that sort of just in case kind of intervention, or we don't know what's going to happen, it's unpredictable, so just in case we'll put together interventions. But that just in case can happen forever, you know what I mean? There's no end to that just in case. So we know this also happens in the context of enormous anxiety. So some community mental health nurses I interviewed think managing and holding high risk cases is a frightening thing. Is it worth putting my registration on the line to take this gamble? Because it is a gamble always. And people think we live in a blame culture and we are sitting ducks. And there's that complexity of anxiety, which is around anxiety around not wanting a person to come to harm, but also an anxiety around what's going to happen to me. Am I also going to lose my job or lose my registration or be investigated or get in lots of trouble myself if something happens? And that complicates the decision-making process. So containing risk in the short term can keep a person safe, but importantly as well, if we're thinking more about that long-term risk, tolerating risk in the short time might promote a person's long-term independence. Okay, next slide, please. I'll try to keep an eye on my time as well. I think I'm doing okay. So long-term. Now, crisis intervention in this Cochrane review from 2012 defined immediate response by one or more individuals to acute distress experienced by another individual, which is designed to ensure safety and recovery and lasts no longer than 1 month. So when I'm thinking about long-term, I'm thinking about longer than a month, because I think that often when you're working in the context of crisis, if you are treating a crisis, which is normally, I guess, fueled by emotional dysregulation, impulsivity, and actually people normally sort of restabilize kind of naturally, you know what I mean, within a few days, you know what I mean, to a week sort of maximum, you know what I mean? I think that there's some writing that talks about between 24 and 72 hours. So if you've got a person that is in being contained beyond a month, that goes into long-term territory. That's kind of not really a crisis intervention at that point. And we do enter very different territory at that point in time, and it becomes much more relationally complex. Nice say, while risk to self and others must not be dismissed, it's also important to distinguish between long-term risks and acute ones, and a failure to do so can lead to an exaggerated and inappropriate response to long-term risks. And this is where, you end up with people in hospital for up to 4 years, is kind of some of my experiences. And it's not a good thing for anyone, is it? So there can be no recovery without tolerating some risk. And I think really importantly, containment is not treatment. Just because a person is in hospital, that might be containing risk, but that's not necessarily synonymous with providing treatment. And we shouldn't kind of get those things mistaken at all. And this was a person said they agreed that actually for them hospital admission was to make sure you're safe rather than treating you. It's not my belief that we can't be useful in hospital, but I think that actually the reality of the resources and what happens often in acute inpatient units is that it does get focused around containing risk. I think David Pilgrim talks about them as risk containers rather than treatment units. I think you can still be psychologically useful within these environments, but I think there's a complexity to them that sort of long-term treatment, they're not always set up to be able to provide that. I don't want people to misunderstand me and think that I think that that's impossible, but I think it would require a redesign in terms of the way things are working just now. And people can be kept alive but experience a social death, where a person loses social identity and social connectedness. And it's easy for us to say that keeping a person alive is a good thing, and it is, but isn't there an ethical implication in sort of keeping a person in hospital so long that they lose coping mechanisms, etc.? Next slide, please. So some of the consequences of containing risk in the long term. Now, creating dependence through risk aversion and clinical anxiety. One of the psychologists I spoke to noted, I was like having to rehabilitate people who have been diagnosed BPD, but have been living in a hospital for 4 years because people are so risk averse and so afraid of kind of what they would do to themselves. And that's the example of that sort of social death that I was kind of talking about. That can't be a good thing. That feels like an inappropriate or exaggerated response to a long-term risk. And a crisis intervention should not last 4 years, because what happens is you just get a recurrent crisis or a cycle of crisis that happens in the hospital environment, and it gets much more complicated and messy. Now, the idea of dependence is really controversial, and I want to be really clear about what I think here. So my hot take is that when we're thinking about dependence, we shouldn't depend on physical interventions forever. So we shouldn't depend on the use of continuous intervention or observations. We shouldn't depend on the use of hospitals, people being in hospital forever. We shouldn't depend necessarily on medicating people too much forever. But we should be able to depend on relationships with staff. I absolutely agree that. And I really don't want to get misunderstood with this, because I think it is appropriate for a person to feel like they can depend on people around them to care and try and understand and empathize and try and help them mentalize, but without depending on essentially keeping them safe by containing. I think that's the only way to kind of think about this. And it's the paradox of attachment, isn't it, from attachment theory, that actually dependence fosters independence. And if you've got somebody that you feel that you can rely on emotionally, psychologically, then perhaps that gives you the confidence to develop more of that independence. Alienation. Now, because there's lots of anxiety involved in this, and it does get much more relationally complex long term. Relationships can break down and people can feel worse. So this a person said, I felt like they couldn't stand me, all the other staff in the ward. I felt like they genuinely hate me. It's just a horrible feeling to have from people. that are supposed to be helping you, in that sense that everybody hates you all the time, that you get from too many people in services. It's just counterproductive. And there's a concept called a malignant alienation, where relationships break down between staff and service users. And actually what this does is it fuels a person's sense of low self-worth, low self-esteem, and actually increases the likelihood that that person will kill themselves and attempt suicide. So incredibly important to think about the complexity of relationships there as well. And the evolution of risk as well is that we can't eliminate risk, so it just changes. A person saying being cooped up all the time actually sends me the other way. This frustration, violence towards myself, aggression and stuff, it builds up because I have no way of like expelling my energy. And again, that's that bit of, if we remove a person's coping mechanisms, then it'll come out in other ways. And so risk isn't eliminated, it changes. And there's a kind of concept called malignant regression, where actually a person's self-harm and suicidality actually becomes worse in the hospital environment. And actually it sort of goes backwards as well. Okay, next slide, please. Okay, I'm on the home stretch now. I've got kind of about 6 slides left. So tolerating risk in the long term. Now, the anxiety remains for people. I think it's important to recognize that. I still work with people, do kind of a bit of therapy privately, and I still feel that anxiety all the time, a little bit of that uncertainty. I think it's important to acknowledge that. I don't think there exists a world where we're not potentially going to be a bit worried about the people that we're working with, because it's the nature of unpredictability of mental health and what's going to happen. And, you know, I mean, mental states can change really, really rapidly. So a person saying it is a gamble always. And I think there is a bit of that. Like, I think that we can't sort of control everything forever. I don't think it's possible. I think the best way we can do it is relationally. Again, complicated. I'm emphasizing that a lot, but I guess that's the takeaway. Now, if you tolerate risk long term, I think that's an opportunity for a person to develop their own coping mechanisms. You know what I mean? So I guess the opposite of that social death is that they sort of move towards that autonomy and that life, that control over their own life and freedom. But I want to be, this is a really important caveat here. This will not happen miraculously by tolerating risk, and will require additional but more focused intervention. Because I think there's sometimes a misunderstanding that actually we need to not give interventions so that people develop their own coping mechanisms. So we don't intervene and actually develop your own coping mechanisms. But actually, I think it's not about not intervening, but it's just about maybe not containing and providing a more useful intervention, you know, I mean, which I would say has to be relational and has to be psychological. And this is 2 people that I spoke to. So a person described discussing with their mental health team. They were just like, you're too unstable for therapy right now. I'm like, well, if I had therapy before, I probably wouldn't have got that unstable. My CPN's like, you need 3 months of stability, then we could re-refer you. But how do I get stable for 3 months without any help? That makes no sense to me, because the whole time with my team, they've been like, it sounds like you need therapy. It sounds like we're stuck in this vicious cycle. And a person felt the ethos was the only thing that's going to work for you is therapy, but we're not going to give you therapy because you can't stop self-harming. And something I wrote about in my thesis is actually this kind of black hole that people with the diagnosis of personality disorder can fall into, because in some senses they're described as not real mental illness, which I think is a semantic debate rather than anything else, you know what I mean, because they're in distress and they need help and we should help them. But as well as being described as kind of not real mental illness, it's also described as too unstable for therapy. So you've got this horrible black hole that you fall into where you're not ill, but you're also too ill. And I think that's something that services need to think about as well. Next slide, please. And I guess just to sort of add to that, the long-term management still requires you to look for those sort of spikes of acute risk. Now, the interpretation of motive, this is incredibly important when we think about the decisions that occur and what happens. So it's not just what professionals do, but how do you communicate what you do? How do people understand what you do? And when we're thinking about people, there's lots of people or lots of stakeholders involved here. So people can include patients, service users, families, colleagues, professional bodies, you know what I mean? Because you can be worried about not just what you do, but how does my patient understand what I'm doing? How's my colleague understand it? How's the Nursing Midwifery Council or the GMC? How are they going to understand what I've done and what I've documented here? I think this is in our head. This is sort of comes with all the anxiety around risk. And other services and agencies, you know, I mean, how do the police view a decision made by mental health services? That's a massive kind of minefield as well. Organization, the media, you know, I mean, kind of how's social media going to interpret this? How is the newspapers, if anyone reads them anymore, how are these going to be? How are these decisions going to be interpreted? And how do people's potential understandings or misunderstandings influence decision making? Because I think that sometimes we can be tricked into thinking that you know, containing risk is always the right thing, because you can always justify it as caring and compassionate. You can always say, well, we restrained them because they were going to kill themselves and they would have died without that. And maybe the thinking can kind of stop there. You can always sort of justify that to a lay person, or you know what I mean, to kind of somebody in the street, and often to sort of regulators as well. But actually, we're sometimes missing that consequence of how does a person feel in the midst of that care. Now, the key concepts here, I think, are mentalization. I mean, I think the interpretation of motive, I developed this probably at the same time as I was kind of learning about mentalization-based treatment. And I think mentalizing is an incredibly important and incredibly valuable model for thinking about the mind and thinking about social relationships and interpersonal relationships. And I would sell that to anyone. I think if you can sort of link a mentalizing model to this model, then I think that helps massively. And I know Andy will sort of talk about that. So mentalization, empathy, transparency, you know what I mean, really communicating, this is why I'm making this decision, because a person might feel neglected unless you communicate why you've made a decision. They might feel that you enjoy controlling them unless you communicate your decision. And appropriate use of self, you know what I mean, particularly when you are talking about your own sort of thoughts and feelings around that decision-making process, you know what I mean, that sort of comes with the mentalizing model as well. And some potential understandings that people have kind of felt have been, I think there's some level of having my control taken away, especially because I wasn't rational. I wasn't in my right mindset. So people are saying, like, I kind of get why people might have contained me, might have intervened, but there was times where it was definitely going too far. So people feeling that they could sort of see where staff were coming from, but it went too far. It was more than what they needed. Other more kind of horrible kind of feelings that people have, it's quicker just to restrain you than it is to listen to you. So people feeling that actually it's really about that kind of control, that people just wanted to control the situation. Somebody else saying they would rather chop their own arm off than admit a person with EUPD in the middle of the night. So these are some of the potential understandings of decisions. So unless we really, really communicate what is going on, then people might have these understandings. So I think just sort of summarizing this, it's about thinking of the containment, and does the containment come across as care and compassion? All right, you contain, so you really care. Okay, I get that. Or does it come across as you control and actually you enjoy controlling me? Comes across as this kind of punitive control. It's not experienced as compassionate at all. And I think the tolerating risk as well, does that come across as, oh, you're letting this happen, you're neglecting me? Or does it come across as, no, I actually trust you care, and actually you respect my autonomy, and you're actually trying to help me find my own life. You know what I mean? You're trying to help me live here. So these can be experienced in very, very different ways. Next slide, please. So I won't labour this point. This kind of, again, you can sort of find these references and look at them in more depth. But iatrogenic harm is the harm that can come from the help, basically. You know what I mean? It's the harm that can come from mental health care. And an analogy that we've used, myself and my friend Chris Young, shout out to Chris, that I wrote this chapter with, and he kind of brought this analogy in, which I think is a good analogy. Talk about how potentially if you're putting out a fire, but then what's left at the end, you know what I mean? And thinking about the water damage that is left at the end. And again, that person saying it was sort of two recoveries at once. So thinking about what is the consequence of putting out that fire or containment or whatever we're trying to do to intervene. Next slide, please. And this is just, again, a cycle of how we can potentially make it worse and get stuck in this self-defeating cycle of risk management that adds to risk rather than alleviating risk, because you don't manage the risk at all. You just sort of, it's almost like, I guess you could build on the previous analogy, and instead of kind of pouring water on the fire, you're actually pouring petrol on it sometimes. And a person felt that mental health services could increase the risk by the atmosphere of the hospital and the reactions that people get. So this model just talks about a risk being identified in a service user, measures put in place to contain the risk by addressing the means and method, you know what I mean? So potentially the way that a person might harm themselves and the ability to do that. But the containment actually contributes to the service user's distress. The service user feels worse, and actually they feel worse, so they feel more likely to act on risk, you know what I mean? So there's maybe that malignant alienation or the regression or whatever. So then you've got a state of changed or increased risk, and then you start again. So we've got the risk, and then we try and contain it, and we just go round and round in this horrible cycle. Next slide, please. 2 slides left. I think I'll make it. Oh no, sorry, can we do the last slide? So I've used this analogy before. I'm doing it online, so I don't have an actual kind of jelly with me, although I did bring a jelly into my third year students that I taught sort of just last year. I think this is a useful way of thinking about it, and I'll read this out. So jelly in your hand. So risk can never be completely eliminated, only changed. If a service user is contained in the long term with increasing restriction, risk will simply evolve. Using an analogy, if you hold a piece of jelly in your hand, close your hand and try to contain it more and more, no matter how hard you press, it will gradually flow outside your hand and through your fingers. In the same way, if a person's distressed and contained more and more, removal of means and method of enacting risk may simply force a person to reconsider means and method. And containing risk in of itself is not treatment, and therapeutic responses need to address underlying distress. So if you try and squash a jelly, you contain more and more and more, you actually just make a mess. The risk explodes out. You cannot contain it. You cannot eliminate risk. You can only change it. Next slide, please. And this is the slide that I'll finish on, and hopefully you've kind of got a sense of this is what I've been sort of getting at. So containing risk through a relationship. Now, containment's defined and enacted in different ways. So the act, process, and means of keeping something within limits. I've talked about being physical, chemical, legal, all that kind of stuff. But emotional containment, this quote here, holding and containing involves a capacity to do nothing, to be with the patient. Now, I would argue actually that we are doing something, but it sometimes looks like we're doing nothing. And I think that complicates it, because sometimes we feel that sitting with someone and listening isn't as professional as kind of, you know, I mean, getting a tablet or a medication, but it absolutely is. That's what the job should be about. That's why I wanted to do it. It's probably why lots of people wanted to do it. But crisis care often responds to behavior, the self-harm and the suicide, but doesn't address the underlying distress. So we need to get better at that. And we need to get to the point of sharing risk. So being without the need to fix the problem or squash it or contain it, being transparent with your mental state and what you're thinking and why you make decisions. Empathy and understanding as an intervention. That was a community mental health nurse that I interviewed that said that he was with a person with lots of complicated problems, lots of sort of risky history, was terrified. He said she didn't know what to do, so just try to understand, and that's what she needed. That's what contained the risk, was her feeling understood. And being least restrictive and genuinely collaborating on decision making and including family, if agreeable. And just to sort of finish with a brief anecdote, because I felt this. I remember being a staff nurse working in an acute inpatient unit and working with someone who had escalating self-harm and suicidality, and feeling terrified, and getting to the point where we sat down together, and she said, I don't know how to stop doing this. And I said, you know what, I'm not exactly sure how to help either. And I think it was the first moment that we probably both were honest with one another and really sort of felt that connection and trust. But from that point, because containment wasn't working, it was just making it worse. And we just said, right, whenever you're thinking this or feeling this, or you think you're going to hurt yourself, can you just come and tell me, and we'll talk. And we did that. And again, I sat and I did nothing. I did something, but I did lots of sort of psychological stuff. I did mentalize and I cared, but I did nothing containing other than the relational containing. And that's what helped that person. And that's one that sticks in my mind, because, you know, I mean, I got a card at the end of that admission, and it said, I know I wasn't always easy to work with, but I always felt like you cared. And that has completely stuck with me for my entire career. And I kind of really stick with that bit of, if people can really feel like you care, you can contain some of that risk. You don't need to do all that stuff. So my last kind of little thing here is, so we don't drop the jelly, right? If you're a bit careless and tolerate too much, you're going to drop the jelly. It's easy to drop it. It's really wobbly. But you don't squash the jelly, because you squash the jelly, it just goes everywhere. So we have to contain it, and that means holding it gently. And that means containing risk through a relationship. Okay, I think I've done not too bad for time there. So thank you very much. I think the next few slides are just some links and contact details and all that stuff. If anyone wants any of this writing, hopefully you can access some of it. If not, I can give you, you can email me and I can send you some stuff. And I think there's a jelly, which will be my last slide, just as a reminder. And then we can move on. So thank you very much for listening. Hopefully it was okay. I've got no sense of how it's really been going down. I've seen a few claps and stuff like that, but just no faces. And I'm looking forward to hearing from Andy and how they've used the model as well.
Thank you so much, Dan. I don't know, when you say I've seen a few, you should see the amount of thumbs up and hearts and rounds of applause you are receiving, and the chat is full of thank yous and full of what an interesting, thought-provoking, useful presentation that was. So much to pick up on there. We've got people with their hands up, but unfortunately we haven't got the capacity within this forum to have people coming in just now. We so do please put your questions, your comments, whatever you like in the chat. And I really appreciated that people, I don't know if you could see this, Dan, but people did thumbs up and claps, rounds of applause, and hearts throughout the presentation. So really, when people were getting involved with what you were talking about, which I think I mean, you know, I think it really struck a chord with hundreds of the people here. So thank you so much for your time today, and we'll come back to you with the Q&A. I think my favourite quote was, all models are wrong, but some are useful, you know, as a lesson for life. It's really quite, you could apply that in many different contexts. So thank you, and thank you everybody for your comments and the discussion in the chat and so on. And Jane and Ashley, I know, will be working hard in the background to theme some of that and to bring it to the question and answer session, which will be shortly. So we're going to move on at this point. Hopefully everybody's stood up, sat down and is ready now. You know, the rustle of papers in a conference hall, the making sure you've had your sip of water. For our next speaker. So our next speaker is Dr. Andy Williams. She is a consultant medical psychotherapist at NHS Greater Glasgow and Clyde. She is dual trained in general adult psychiatry and psychotherapy, and has really developed and pursued an interest in how care is delivered and experienced for people who've got a diagnosis of personality disorder. She's had a role as clinical lead for the personality disorder and homelessness team for the past 18 years within Greater Glasgow and Clyde. And for those of you that are unfamiliar with Scotland's health board, GGC is the largest health board in Scotland. So it really sees a large volume of people and a lot of complexity. Andy has worked with us within Healthcare Improvement Scotland on phase 1 of the Personality Disorder Improvement Programme, and we're delighted to have her here with us today. She's also been involved at a regional or local level in the development of the borderline personality disorder pathway in NHS GGC, and she led on the Royal College of Psychiatrists report, raising awareness, raising expectations and raising hope, which in 2018 contributed to the establishment of the work within Healthcare Improvement Scotland around improving care and support for those people with the diagnosis of personality disorder. So, Andy, without further ado, it's delightful to have you here with us, and you're going to talk to us this morning about the clinical application of the action consequences model across clinical pathways. So over to you, Andy, and then it will be questions and answers. Thanks very much.
Thank you so much, Rachel, for that fantastic introduction. And Dan, cheers, mate, for giving me something impossible to follow. But I really hope that I can follow on from Dan's really inspiring work to give you a bit of a flavour of how we've utilised and found this model helpful across our pathway in GGC. So like Rachel said, I've got this hat as clinical lead for personality disorder in GGC. And also my day job is working in a specialist homeless personality disorder service where I've been for almost 20 years now. And in that job and in all my other sort of interests around this area, we're often faced with thinking about really complex, risky situations. I suppose our team in my day job, we're asked to consult sometimes on complex patients and situations. And over the years, I've had different ways of thinking about it and trying to bring my psychoanalytic training and my MBT training to bear on some of the situations that we see and try and kind of help services to work with. And then Dan came along with this model. And this model just started to make sense to me clinically. I started to find ways to use it in practice. We used it in practice as a service, and it just started to grow a little bit organically. And as we used it, I was interested to see how other people did just seem to pick it up and find it useful. And I think that's been the key factor about this model for me is that it just seems to have grown, and to the extent that then we started to kind of more formally use it and embed it in some of our pathway thinking in Glasgow. You know, for example, psychology colleagues picked it up to think about lengthy inpatient stays and people who are on extended observations or continuous intervention. And psychiatry colleagues, so different professionals, different settings, people just seem to have picked it up and started using it. And I think that's because it's both simple and complex. It's simple in its layout and it's usable, but I think it allows for complexity of thinking. And I suppose that appeals to me as a psychotherapist and the kind of things we get into thinking about the complexities of these interpersonal situations that we get into. But it seems to be simple enough to be usable and applicable no matter what your sort of background training is. Can I have the next slide, please? So yes, like Rachel says, NHS GGC is a huge health board. My understanding is it's the biggest single healthcare system, even in the UK. So it's a big ship to steer and to make any changes. And we've had a mental health strategy that really started back in 2018 that I've been involved with as clinical lead. And it's been refreshed again in 2023. And part of that strategy is developing this system-wide kind of way of thinking about people with this diagnosis who present to our services in all sorts of different ways. And as part of that, we have a lived experience reference group who influence all aspects of the strategy and contribute to various aspects of the strategy and the delivery of service. We have a strand of training around increasing staff knowledge and awareness around personality disorder to try and challenge some of the myths that I saw pop up in the chat earlier about this being an untreatable condition. Things like improving equity of access to evidence-based treatment. So we've got kind of programs of treatment that we're trying to kind of improve and strengthen and improve the pathways to. And I guess underlying some of that are kind of preoccupations of our managers. And I saw other discussions in the chat about the pressure on beds across services in Scotland. And one of the things that having good treatment in place in community settings for people with this diagnosis may help. Have the next slide, please. So our strategy has a whole lot of layers to it. And I'm just going to talk about the layers of the strategy where we've tried to introduce Dan's model in a slightly more organised way. So like I said, it came about because of it just showing itself to be useful and clinically applicable in a lot of context. And so we've started bringing it into some of our basic training. So that the biggest box there is our CCC training, our coordinated clinical care training. And I'll go on to describe each of these layers a little bit over the next couple of slides. So we introduced the concept of ethical risk management and introduced Dan's model sort of during the training days that we offer to all staff across adult mental health. And we support it by sort of giving examples of how you can use it in practice and provide people with a sort of template to use in practice. We've also brought it into our guidance documents. So that's the kind of layer of documentation and materials that we leave people with after their training, in the hope that we can start to embed some of the thinking and some of the practice into everyday working lives across inpatients, outpatients, crisis, mental health assessment unit. So we have different documents, for example, one on crisis presentations and one on inpatient care and good practice. And the model sits there as well with sort of templates to use and ways to kind of bring this into multidisciplinary discussions. And then we have a layer that we've called our clinical risk reference panel, and I'll describe that a little bit in more detail. And that may answer, I saw a question in the chat from Gordon about what about organisational responses to risk? You know, this shouldn't be something that sits with an individual clinician or even an individual team sometimes when risks are great, that there has to be something of an organisational response. So I'll describe each of these in a little bit more detail to kind of give you a flavour of it. Can I have the next one, please? So our training for staff, this is core training as we expect and hope. We've got a kind of an ambitious plan to have this open rolling training programme for all staff across adult mental health settings. And it's based on good practice guidelines like NICE guidelines and other guidelines which underpin the pathway with an aim to just improve staff's knowledge, confidence, understanding. There's a core strand to the training that thinks about attachment, about relationships, about promoting empathic and validating stances. Our training model's based on all of the therapy models that are available across GG&C. So we have DBT, MBT, STEPS, psychodynamic therapy, we have schema therapy available. So we've drawn from all the models to kind of distill some core principles and stances that we try to kind of get across and promote across all aspects of the pathway. And the model has been co-produced in terms of its content, and we're working towards a bigger component of co-delivery of the training with people with lived experience. So that's our model. I can have the next one that just describes it in general. And our underpinning principles, I haven't listed them all for you, but I've just selected out a little subset of the underpinning principles for our training and for our whole pathway. And the middle one there, the thoughtful approach to risk. We spent a lot of time thinking about the wording of this. We didn't want to frame it as positive risk-taking because that can sometimes be kind of pushed into a kind of unhelpful black or white sort of tolerating too much risk and services stepping back and not taking any responsibility like Dan was describing. So we framed it as a thoughtful approach to risk. And this is where the model we think has been particularly helpful because it gives us a framework within which to think. And you'll see with the points above and below that we're also emphasising collaborative and shared working, and that also applies to our use of this model of thinking about risk, that where possible, where meaningful, that we try to do this with patients, with the people that we're working with, that we get patients and families on board with our thinking around why we're taking a particular approach to risk, as well as using it within the team setting and the members of the sort of professional members of the team. Because the idea here is that we want to think about how we tolerate uncertainty. We want to remain open and curious. We want to be willing to change our minds. And so all of these sort of principles, which for me fit well with an MBT model, but as others have pointed out in the chat, it fits with other therapy models as well. Keeping ourselves in that grey zone, not getting into the black and white so much. And I want to show you on the next slide just one of the risks of that. So I thought the zone we want to stay in is exactly the non-binary zone. We want to remain thoughtful. We don't want to get into an unthinking or blaming sort of perspective that can sometimes be hidden under a banner of positive risk-taking. And I think one of the ways people may be aware of this project called Serenity Integrated Mentoring, which was sort of taken on rather wholesale by some trusts in England, which provoked a huge response and objection from people with lived experience and many other organisations. You may want to read a little bit around it, but part of this model was to bring police into mental health teams and to utilise pressure through things like prosecution in order to kind of force responsibility onto patients who might be presenting with distress. So for high users of service, there was a stance of beginning to sort of move away from sort of services feeling that they had any responsibility for actually working with that distress, and seem to move much more to an extreme position of these are people who need to be treated through sort of excluding and even criminal sanctions. So there's a lot of detail on that slide to the right, but it's an interesting, very strong response from NICE finally in response to many of the objections to this model, that actually it was aversive, it was punitive, it was rather a black and white response, and it's now considered not to be an appropriate way to work with people who present with high risk. I think there's a difference. The way I would describe it in my words is there's a difference between the kind of phrases that we use sometimes about, that's your decision. I'm sure people have heard that kind of language being used when someone presents in crisis, that you've got capacity. So the kind of black and whiteness about having capacity or not capacity, having responsibility, not responsibility. And I think there's a difference between that and a stance that we might promote, which would be help someone to develop that capacity and autonomy to manage their emotions over time and through the use of good relationships and containment, as Dan was describing. So I think we can see here the risks of things becoming black and white, binary. And I think from my psychodynamic perspective, these kind of responses that we come to sometimes that become extreme, you can see unconscious processes playing out here. Our uncertainty and our anxiety pushes us into very black and white, very easy solutions. And I think where Dan's model comes in is to hold us in the thinking, contemplative and processing sort of position that might help us to respond more thoughtfully. Can you give us the next slide, please? So as part of our other layers that I was showing you in terms of where we've introduced the model in our pathways in GGNC, we have our guidance documents. These are sort of 3 to 4 to 5 page long documents with a bit more detail for staff to kind of pull out if they're really struggling. And we've got guidance documents around these different areas, around managing crisis, around thinking about inpatient care. We're working on a document about where situations have become quite stuck or where someone has ended up in an extended inpatient state, where things might have become more complex and more challenging. And these guidance documents have materials with them. So things like a template of the model. And interestingly, that somebody on the call on the webinar today from Project AIR, because I was going to mention that we draw on other documents from other places, and we've drawn heavily actually on some of the Project AIR materials that have been extremely helpful. I'll just show you on the next slide what we include in terms of the DANS model within some of these documents. So it's just what you've seen before. Dan's taken us through this, and we have a version of it which is a bit sort of more of an A4 size than this page, and it's just with space for people to kind of populate this with a description of what's going on in the particular situation that we're thinking about. What is the action that we're thinking about? Are we talking about a question about reducing observations? Are we talking about a question about admission to hospital or not? What's the actual action that we're thinking about here? And we invite people to, as a team, use this model to populate the boxes in discussion, to weigh things up in a bit of detail, to use this to explore different views amongst the team. You know, sometimes we have situations with strongly different views between different professional groups, between different individuals. And if, as I was saying before, if possible, involve patients and their families, because I guess by going through this process, by meticulously kind of thinking about all of these aspects of care, particularly the tricky last column here, I think, that potential interpretation of motive, I think that sometimes it's a thing that is unspoken, unthought about. And I think that's one of the values of this model, that we can actually stop and think about what are the other factors playing in here that are making us more anxious about doing this, or making us more worried about our reputation, making us more worried about how we'll be seen by colleagues. You know, does it look tough and like you're a good gung-ho consultant if you're tolerating lots of risk and taking positive, doing positive risk taking, or does it make you look uncaring and harsh? It's being aware of some of those kind of things that might be going on in us, about what we might normally not think about so much, which do, I think it's clear it does actually affect our decision making. And the other factor we try and get across about using a model like this is you can do this in an MDT meeting, you can populate it, you can pick it apart, you can also change it, you can also shift it, you can also come back and revisit it if something's changed a little in the situation, if you've understood something more about one of these one of the aspects in one of these boxes. We're open to revisit it, to be flexible, to use it as an active document. And we have found it really useful, I think, talking with patients and families about why we might be making particular decisions, and with police colleagues, for example, that just getting across a kind of rationale for why you might be making a particular decision based on this complex set of understandings about what's going on. So that's at the day-to-day guidance document level in our pathway. Can you put up the next slide? And the final area that we use it in regularly is in this model of a clinical risk reference panel. This is something we introduced into our pathway to deal with probably some of the most challenging situations, often where somebody has perhaps got stuck in hospital for a long period of time and it's felt that the care isn't particularly helpful, but that there's still a high level of worry about risk and there's a difficulty in moving things on in any sort of productive way. And this is a model where we understand that in most practice, teams manage risk, they think about it, they have models like MDT meetings, formulations, using your clinical psychology input, complex case discussions, maybe second opinions. Usually that's enough in most teams to kind of think about things and come up with a plan. But in a small number of cases, there might be a higher level of worry, a high level of maybe disagreement in a team, a worry about whether there's organizational backup for a decision-making process. And that's where we developed this clinical risk reference panel based on other models, particularly one in Wales that I've referenced there that we used to have a look at. And we, as part of that, build in the action consequences model to think about it. So this is where a whole clinical team makes a referral to the panel. It's a rather time-consuming model. If you put up the next slide, we have a sort of expert panel. We include senior managers in that panel. It's embedded within our governance structures. And the hope is that it allows for a sort of provision of an externality and an organisational holding of this thinking and reflection in these complex and ethically challenging scenarios. So the team presents a case, they send on materials, the panel sort of looks at all those materials and the case in detail. Then there's a sort of shared discussion meeting, at least one, maybe two, with the team. And then the panel sort of go away and use some of the ethics of risk management thinking to help formulate a response. We've had difficulties with the model, I guess, in that it's time consuming and quite onerous, but it has been found to be quite useful and helpful to staff. It would be nice if it were more agile and could respond in real time, but as you can hear, it probably takes some time to do this carefully and well. But it's just another example of how you can organisationally embed this kind of complex thinking but with a model that helps us to kind of simplify our rationales and thinking. So it helps us to frame back to the referring team really our formulation and our reasoning for a kind of a course of action, and that feels helpful to teams in order to think about what steps going to be taken next. I'll just put up the next slide, please. I'm rather over time, so I'm not going to go into huge detail on this. This was going to bring us back to just a kind of more clinical focus again. I've taken you through the layers of our pathway and how we apply the model. This was just an example of a kind of summary of how we've used it in our MBT-based psychotherapy service, working with people who've experienced homelessness and personality disorder and have also had high use of services. And we've used this model sort of over a series of cases. And we found there was a nice mesh between the MBT model and Dan's model in terms of some things he was just mentioning, I think, about the flexibility and openness of teams to actually think about what their emotional responses are to the situation or to the particular patient or to the particular risk. We have down the left-hand side just some of the kind of quite honest reflections from staff and the value of discussing this as a whole team and remaining curious and open to hearing those different perspectives and trying to include all of that in populating the model and moving towards an agreed way of working as a team. I was going to give you an example in some more detail. I will hold that actually and just go to the last slide so that I can leave time for questions. And I think in summary, for me, it as Dan said, I think it's not a simple solution. It doesn't answer a question simply or perfectly, but I do find it to be a versatile framework to promote thinking and reflection in ourselves and teams, including, I think the main way we've been using it is to promote team thinking, but I've also reflected recently it's a good model to actually just do some self-reflecting, particularly about maybe some of those more uncomfortable feelings we have sometimes. This is my psychodynamic psychotherapist coming out to really reflect on what might be some of the things playing out in our minds that are leading us to be maybe more punitive or more rejecting of somebody and sort of under the framework of positive risk-taking, or becoming too anxious and over-caring. But as much as possible using it in a team model to reflect on how we're responding. And I think it's applicable, as I said, across our systems and including right up to management level and our governance systems. It seems to have been an applicable model that people have got on board with. And I suppose future plans, we're hoping to kind of build a little bit of a mini network of clinicians across the UK. We've got colleagues certainly in Cornwall and Tayside that we know of that are using the model, and we hope to kind of come together to keep exploring its usefulness. Thank you. I'll stop there.
Thank you so much, Andy. And I don't know if you can see all the applause and the comments in the chat and the people with their hands up. I think there are people who are desperate to come in. Oh, there's a flurry of applause. Thank you so much. It was so helpful to see that in action, to see the model, not just as a model, and Dan's great critique of his own work, but then to hear about how it applies day to day for yourselves and your colleagues in Greater Glasgow and Clyde. So that was a really, really helpful, tangible implementation piece. Thank you for that. I'm really aware that we have about 2 hours worth of discussion that we could have through the question and answer session, and we don't have that much time. Before we do that, we would really like to hear from you. It's really important. You've shown us through you know, the various ways that you can interact, how much you're appreciating and getting from the presentations so far. So we've just got 5 really short, really quick questions, and then we're going to hand on to Jane for the Q&A session. So there are going to be some polls coming onto your screen. Please do vote as soon as you can. Each one will appear once once you've done that one. So please rate. So the questions are from 1 to 5. Rate your level of satisfaction with today's event. Would you recommend these events to your colleagues and peers? What learning will you take away from today's event? You can do multiple choice. You can do a word cloud, you know. And did this event increase your understanding of how risk can be approached and managed for people with a diagnosis of personality disorder? And did it change your understanding about approaches for risk for people with a diagnosis of personality disorder? So they are the questions. You'll see that you've got strongly agree to strongly disagree. Please do just pop your answers into those polls. And I think while people are doing that, I will introduce Jane. I'm delighted that Jane is going to be taking and facilitating the Q&A session. Jane is the Strategic National Clinical Lead for Mental Health at Healthcare Improvement Scotland, as well as being a consultant psychiatrist for NHS Lothian, based in the Royal Edinburgh Hospital. Jane, if you would like to take over now, and we will come to the questions and comments that people have put in the chat. And thanks, Dan, for having your camera on. That's great. So here we are.
Perfect. Can everyone hear me okay?
Yes.
Yeah.
That's fine.
Fantastic. So first of all, thank you very much to both Andy and Dan. I don't think I've ever seen so many hearts, claps and thumbs up scattering a screen on a Teams meeting. So it's clearly been very thought-provoking, and there are lots, as you might imagine, of questions, some of them quite specific in the chat, and we won't have time necessarily to pick out all of them. So I'm going to try and ask you some in more kind of themes type ways, picking up on some of the things that people have asked. The first thing that came through quite strongly, I think, in the kind of questions that people were posing, and you touched on it, but I wondered if you could say more about it. There was lots of comments about how do we reconcile the ideas you're talking about with some of the issues around there still being a blame culture, you know, that people still do want, the rest of the world want black and white answers, SAERs want black and white answers. How do we kind of move away from this and support clinicians to work in this way, which, you know, from certainly from the questions and comments, everyone seems enthusiastic about working in this way and sees this as the way forward. So what are your thoughts about how we might kind of square that circle or work with that?
I'm assuming because it's a difficult question, that one was for Andy, is that right?
Well, maybe
I was assuming the opposite.
Dan, and then Andy can maybe talk about how she's seen that work on the ground in GGC.
Yeah, I mean, I think sometimes when you get into these questions, it does almost feel like you want that kind of world too. You know what I mean? Can we just reset and then build up from the ground again? Because how much do we have to change to get into that place? I think some of the stuff that Andy talked about, you know what I mean, around having organizational support and understanding of the difficult decisions that are happening is incredibly important. I think that sometimes we have in our society, a bit of a misunderstanding and sometimes a bit of a fantasy, I think, particularly around inpatient care, you know what I mean? Because people hear the word hospital and just think, oh, well, that's where you go and you get your treatment, you know what I mean? And you need to go into hospital and that's where you're going to get help and you're going to be better. You're going to be better after the hospital. And I think that there is, certainly from the nursing regulator, you know what I mean? I think there's a misunderstanding of how different mental health is than other fields of nursing. So I think there's it's one of those sort of multifaceted, wicked problems around not everyone necessarily understanding the kind of complexity of this. I mean, I think that I would review all sort of, I mean, this is my utopian wish list, you know what I mean? But I would look at all kind of professional trainings, you know what I mean, that I think are sometimes not as focused around the ethics and human rights maybe as they could be. And I guess getting to the point, because I know that I went through this journey of, I wasn't immediately able to say out loud that I was scared that someone was going to die. And I was terrified and I didn't feel like I was a good nurse and I felt really inadequate. And actually trying to get to a place where we're all sort of acknowledging that, because we work in these messy, anxious spaces, you know what I mean, where like, how are you supposed to know what to do with a human being, you know what I mean? There's not a kind of a rule book or a guidebook, or, you know what I mean, it's much more kind of complicated than that. And I think if we could start to own some of those vulnerabilities, start to be, I guess, a bit more transparent and honest about the limitations of, this is hospital, this is an acute ward, this has got a place, but this is what it can do, this is what it can't do. This is actually some of the bad things that might happen if you come in here because of the nature of the way it's designed and the limited resources and stuff like that. If we could start to have those conversations, it might kind of steer us in the right direction, but I'm not going to say I've got a better answer than that.
Andy, how have you seen it work in GGC? Did you feel you've been able to move that with the approach?
I think a little, and I think in a much more, I agree with everything Dan's just said, in a very pragmatic way. I think one of the tricks is to get everybody involved, including local managers, you know, senior and junior staff all in the same room, right up to sort of locality managers, service manager kind of level, so that it's clinical directors, it's having a shared understanding across all of those people that actually can tolerate listening to some of what Dan's just described and can actually own some of that as well. Because I think, you know, no matter where you are in that hierarchy, you're going to be subject to some of those anxieties, and having everybody in the room discussing it and sharing an understanding of what the clinical team's facing and concerned about is probably the way to begin to shift it.
And it sounds like your clinical reference group model helps with that, because it diffuses the kind of responsibility and shares that across all levels, rather than it being held with individual clinicians. Because I'm often very struck that, you know, the secondary victim aspect of when something goes wrong and how that impacts on individuals, it sounds like that's an important way of spreading that load, is it?
Yeah, it doesn't solve it or make it more simple, but it spreads it, and it's held in a more conscious and overtly expressed way. Some of the anxieties and underlying sort of factors that might be going on are a bit more out in the open and expressed and documented as well. Actually, that tends to help.
I mean, the next two questions are kind of related, but the other things that came out were around this issue of hospital admission and what place does it have, and should we be using it, knowing that it is re-traumatizing, knowing that there isn't really an evidence base for hospital admission, knowing that patients with conditions where hospital has more to offer, like schizophrenia, mania, are struggling to access hospital beds. It's a very thorny issue, but what are your thoughts around the role of hospital care for this group of patients that are struggling with particularly maybe self-harm?
I think the question for me is sometimes, and again, I remember having this kind of light bulb moment, you know what I mean, of asking, well, what else is there sometimes that is available for people when they are in crisis that they can potentially access. And I remember working in an acute unit where you would see people again and again and again. You know, I mean, somebody would be in for a couple of days and then they'd be home for a couple of days and then they'd be back again. And you think, what is happening here? But then you sort of get that picture of, well, they're not able to access long-term therapy at this point in time. We know that there's been a massive strip back of community services, you know what I mean, over the last kind of 10, 15, 20 years. So what else does this person have? And I think, I mean, that at the very least, it's a question that can allow us to have a little bit more understanding and empathy for people that might come back again and again and again, because we do have to ask, what else is there? And I know that in some areas, you know what I mean, there's certainly a real desire to try and get that, I guess, more accessible walk-in crisis service that's perhaps more non-medical, you know what I mean, thinking about kind of crisis cafes and stuff like that. And shout out to kind of Hope Point in Dundee that I visited and stuff like that, you know what I mean. So these things offer something different. I think they're probably still going to be limited in some circumstances, and I think that it's difficult for me to imagine a world where hospital admission is never warranted, or you know what I mean, there's a point where we could have something that we just wouldn't need that at all. But I think if there are other things that are available, then you can at least sort of save that for very well structured and supported admissions that don't end up spiraling into these big messy things. I think the sharing that decision making, you know what I mean, between multidisciplinary team as well, you know what I mean. I think that I can remember being you know what I mean, a staff nurse and having a very different opinion than psychiatrists that I was working with. And no offense to psychiatrists that I've got lots of time for, especially the folk in this call, but that's a really difficult position to be in, you know what I mean, when a nurse might be on a ward with somebody for 12 hours and a psychiatrist has maybe more of an appointment basis and has a different perspective and different seeing. And we really have to kind of come together in terms of, look, this is what you're seeing, that's really useful, but this is what I'm seeing and you're not seeing that. And can we respect each other's kind of opinions and try and sort of really come together and be honest with one another? I think I rambled away from your question there, but I'll hand over to Andy.
You didn't at all, because you're raising one of the kind of thorny issues around splitting as well, and how, and you touched on it, both of you, and you talked about how teams respond to people, which, you know, is a whole other aspect of this. But so you didn't drift away at all. But I'm curious, what are your thoughts, Andy? Anything different or to add? Or
yeah, I'll just add that pragmatic perspective again. I think, like Dan, it's hard to imagine immediately a world where it isn't part of the pathway of care for people, whether we plan it or not. And what we've tried to introduce through our guidance documents is a kind of model of trying to make it as least harmful as possible and as therapeutic as possible. So a kind of aim of a short admission with a kind of focus and an aim towards back to community-based care as soon as possible, with something active or helpful happening during the admission if possible. That's the ideal. The reality is often, you know, none of that really thinking and decision making happens sometimes in the middle of the night when it's a CT doctor or a mental health assessment unit and they're faced with a lot of anxiety from family and or police and or the person themselves. So yeah, we've got an ideal and a kind of what we're working towards kind of introducing a bit more of, but I think it's kind of a work in progress.
Work in progress. And the other one, the last question, very briefly, again, it seemed to raise, it was one that popped up in the chat, it seemed to raise a lot of responses about, and you've both touched on it, about this way of moving away from ideas of risk assessment, which is very fixed, to risk formulation. And it seems both of your discussions were, that's part and parcel of what you're looking at, this much more kind of dynamic idea.
Yeah, I mean, I think that sometimes risk assessment tools might be something that, again, gives us a bit of comfort around our anxiety. You know what I mean? Because we say, I'm feeling really anxious about this, but I did the form and the form says it's low risk or whatever. And I don't know how a form can kind of do that. I do also think that, you know what I mean, when we have to work relationally, you know what I mean, if you kind of get a sort of risk assessment or something, there's something physically and metaphorically in between your connection with somebody, and sometimes that completely distracts actually from the assessment that could come from really trying to engage with somebody. And of course that's much less tangible and scientific, and it's difficult to kind of replicate because I'm a different person than Andy is and stuff like that, and we're going to see kind of different things. But I think we have to get comfortable with that sort of messy space of there might be some key principles that we keep in mind when we're assessing risk. But actually the idea that we can make it this neat sort of tick box thing that is going to be really, really useful, it's just not realistic. And then you've got the fact of kind of human beings change very, very rapidly. You know what I mean? Mental states change. You know what I mean? I feel all right just now. I might feel very different in sort of 20 minutes, you know what I mean? Depending on things that occur in my life or within my body or whatever. So the idea that we do this risk assessment and then we kind of control or can predict the future in some way, I think we're trying to kid ourselves into a comfortable place. And actually we just need to make peace with the anxiety.
Andy?
Not much to add to that, really. I was going to say something a bit similar, but I do think the whole of these two presentations are edging us towards being a little bit more open and comfortable about the idea of being in an uncertain place with people and trying to discuss that and trying to be open about that between ourselves as professionals, but also in our interaction with the person themselves and what we're planning to do and as collaboratively as possible. But yeah, it's a grey and complex world, and like I said, I think what this model offers is a way of just kind of shaping our thinking in the middle of a kind of difficult situation. It's just a helpful thing to sort of hold on to kind of think through the complexities, which may be changing moment to moment.
Thank you very much. I mean, it seems the overarching, the message that I've heard very strongly is we need to tolerate and work with complexity, messiness, changeability of risk. We need to react compassionately and ensure that people are getting the right care at the right place at the right time for the right length of time. But we need to see this very much in terms of pathways of care and not chunks of individual services, and we need to take a much more kind of joined up approach to risk assessment, risk management, and think about it in a more flexible and patient-centered way. Do you think we've got that gathers the gist of what we've said this morning? Brilliant. Amazing. Well, thank you ever so much, Dan and Andy. Thank you to everyone that's contributed questions in the chat. I know I haven't been able to pick them all up, but they will all be looked at and they will inform work in the area and will inform further webinars. So once again, just thank you to everyone who's taken part this morning. Thanks to our two presenters. And I'm sure we'll all go away into our working days with a lot of food for thought there. So thanks again. Take care. Bye.
Thank you, Jane. Thank you, Andy. Thank you, Dan. I'm just adding my thanks to everyone who's been attending. You have been absolutely great. I hope we can all have a round of applause just now with our small yellow hands. That would be amazing. But thank you, Dan and Andy, for sharing your expertise and your knowledge and bringing that new and refined approach to this incredibly complex area around risk and harm and care. I've just been having a look at the word cloud and it's all about risk, that people have been really picking up on that. And thank you to the team who've been leading this work. Ashley as the delivery lead, Aisling as the improvement advisor leading the implementation, and Nicola, Debs and Rebecca as the tech and event support. And of course, you too, Jane, for supporting the Q&A. And as Jane says, we'll be writing that up. Thank you to everybody who's been here. And I think I just wanted to end with this quote, which was in the chat, which was from someone who says that this is the most thoughtful and useful presentations I've attended for a long time. So I think, Dan and Andy, your work here has gone well. So thank you everybody for this morning, and we will be holding our next webinar on the 1st of May. If you're interested in that, look out for it. And we hope to see you all virtually again soon. Thanks very much, everyone. Bye-bye now.